Hi, my name is Nizul, and this presentation is on hypertension. A couple of objectives for this presentation is first, we will look at what regulates blood pressure and kind of define some of the terms and looking at the formula of blood pressure. Then we'll look at some of the risk factors of hypertension and examine the different types of hypertension that exist, and looking at risk factors that predisposes someone to high blood pressure. We'll also discuss the compensatory mechanisms that can occur with hypertension and also looking at complications that can occur in the body secondary to long-standing uncontrolled hypertension in a patient. So first, one of the things that we'll be looking at is this figure, which is adopted from the Lewis textbook. And we're going to be looking at some of the factors that can potentially influence or impact the blood pressure in the body. But first, what is blood pressure, and understanding what blood pressure is? It is really a force that is being exerted by the blood as it's being pumped out of the heart against the walls of the blood vessel with enough force that it's getting to all your organs to perfuse the organs. There are two big things or two big factors that influences blood pressure, something that we call our cardiac output, and the other is the systemic vascular resistance, where some textbooks or some places this can also be referred to as our peripheral vascular resistance, or PVR. So SVR, PVR pretty much is similar. So when we look at cardiac output, as we go along, we'll see what cardiac output is. Cardiac output really is the amount of blood that is being ejected from the ventricle per minute. So amount of blood ejected from the ventricles per minute. And so when we look at some of the things that can impact the cardiac output, we're seeing one of those things is the heart rate. So the heart rate, how fast the heart is beating, can either increase or it could decrease the cardiac output. The other thing you're looking at is contractility. Contractility is the squeeze. So how hard, or what's the force of the myocardium squeezing to eject its volume or eject the cardiac output. So often a stronger squeeze means more volume is being ejected. If the squeeze or the contractility is not that great, it means that less volume can potentially be ejected from the ventricle of the heart. And then conductivity. So the heart requires a conduction, or it requires an electrical current before it can contract. So if you recall, we have the intrinsic conduction system in the heart. So think about the SA node, the AV node, the bundle of His or the AV bundle, and the Purkinje fiber. So once the conduction happens, then usually what follows after that is myocardial contraction or contractility. So if conduction is good, the next thing that will follow is contraction of the muscle or systole, which means that then that will increase the cardiac output. If your conduction doesn't exist or your conduction is haphazard, then ultimately contractility will be decreased or contractility will not be effective. Systole will not be effective, and so cardiac output can then be decreased. Another thing that you're looking at is what they put in the textbook as the renal fluid volume control, which is otherwise known as the renin-angiotensin-aldosterone system, which is the RAAS. And one thing that is released from the RAAS that can impact your cardiac output is your aldosterone. And so what does aldosterone do? Aldosterone will retain sodium and ultimately retain water. And once that sodium and water is retained, blood volume will go up, which means then stroke volume will be increased and your cardiac output can potentially also be increased. When we look at our systemic vascular resistance or our peripheral vascular resistance, really what that is looking at is what is the force or what's opposing the movement of blood in that blood vessel. And often one of the big things that is really going to impact is the diameter of that blood vessel. Okay, so when we look at the radius or the diameter of that blood vessel, the radius, that's really going to impact our SVR or our PVR. So vessels that are narrow, meaning that their diameter is really small, which you might otherwise say it's a vasoconstricted blood vessel, is going to make that resistance much higher. In other words, you will expect an increase in SVR when vessels are vasoconstricted versus if you have a blood vessel that is vasodilated. So the vessel is really large, you can expect a decrease in SVR, meaning the radius is bigger, there is less resistance against the heart trying to push blood through these blood vessels. So when you look at some things that will impact your SVR, understanding that a vessel that is vasoconstricted will increase the SVR, vessels that are vasodilated will decrease the SVR. One of the first things you're seeing on this diagram is the sympathetic nervous system, and understanding that the sympathetic nervous system has what we call catecholamines, so epi and norepinephrine. And when these catecholamines attach to receptors in the body, for example, alpha-1 and alpha-2 receptors that are located in blood vessels, they cause the blood vessels to vasoconstrict. And therefore, if the blood vessels will vasoconstrict, you're going to start to experience an increase in your SVR. Another thing that is released from the RAAS that we didn't mention earlier is angiotensin 2. And angiotensin 2 is a very potent vasoconstrictor. So angiotensin 2 is a very potent vasoconstrictor. And so similarly to your catecholamines or to epinephrine, when angiotensin 2 attaches to blood vessel, it will cause the blood vessels to vasoconstrict, increasing the SVR or PVR, ultimately increasing the blood vessels, increasing the blood pressure. And so likewise, you want to think about things that will vasodilate the blood vessel. So for example, you're looking at, in this diagram, they talk about prostaglandins. And once we get into more concepts in the course, you'll see things like inflammatory mediators that are being released that has the ability to vasodilate the blood vessel. And once those blood vessels gets vasodilated, it means there's less pressure in there. So the SVR or the PVR starts to decrease, ultimately resulting on or potentially decreasing your blood pressure. So really what you want to do is take this figure and look at understanding what is cardiac output, what are the factors that will impact your cardiac output, because you know that an increase in cardiac output can potentially increase the blood pressure. A decrease in cardiac output will decrease your blood pressure. Likewise, understanding what is SVR or PVR, understanding it is resistance exerted by the diameter of your blood vessel. If blood vessels are really narrow and small, i.e. vasoconstricted, you're going to see more resistance, so an increase in the SVR, likely increasing the blood pressure. If the diameter of the blood vessel is quite large, in the case when blood vessels are vasodilated, there is less resistance, and that can potentially decrease your patient's blood pressure. So the cardiac output is the total amount of blood that flows through the systemic or pulmonary circulation every minute. In other words, the amount of blood that is being ejected from the ventricles, whether that be the right ventricle going into the pulmonary circuit or the left ventricle going into systemic circuit every minute. Cardiac output is really the stroke volume which is the amount of blood that is being kicked out of the ventricle with every contraction or every beat, and that's about 70 to 80 mils of blood in an adult patient, and you're going to multiply that by the heart rate. So stroke volume is cardiac output is stroke volume multiplied by the heart rate. And again, as a recap, your systemic vascular resistance is the force opposing the movement of blood within the blood vessel. And we know that this force is primarily the resistance exerted by that blood vessel based on the diameter of the blood vessel. So vasoconstricted blood vessels will have an increase in SVR because their diameter is narrow, whereas vasodilated blood vessel will have a decrease in the SVR because of a larger diameter or a larger radius. So let's look at some of the receptors that are part of the sympathetic nervous system, where they are located, and what would be the effect once catecholamines, because we know catecholamines are part of SNS, so your epi and norepinephrine, once they bind to these receptors, what would be the outcome? But first, let's look at their location. Alpha 1 and alpha 2 they're in very many places, but for the purposes of this lecture, they're located in the vascular smooth muscle of your blood vessel. Beta 1, always remember there's one heart, so it's located in the heart. And beta 2 is located, think about 2 lungs, is located in the lungs. So once we have catecholamines, or epi and norepinephrine, bind to those receptors, they will have an effect. And really and truly, our biggest effect is looking at what's happening with alpha 1 and with beta 1, again, for the purpose of this class. So when epi and norepinephrine or catecholamines bind to alpha 1 and alpha 1 adrenergic and alpha 2, ultimately this will cause vasoconstriction of the blood vessel. So start to think, if the blood vessels are vasoconstricted, based on the previous slide that we spoke about, think about the diameter of that blood vessel, and once that diameter changes, what does it do with resistance? And going back to the blood pressure formula, blood pressure equal cardiac output multiplied by systemic vascular resistance or peripheral vascular resistance. So once there is vasoconstriction, we know there will be an increase in resistance, and therefore that will start to increase that PVR. Binding to beta 1, it increases the heart rate, and it's going to also increase contractility. And rate and contractility is different. Think about rate as how fast the heart is going. Contractility is how hard the heart is squeezing. And so once where the heart is going fast, depending, now not too fast, it has to be going to a certain rate that still allows for filling, then that could increase the cardiac output, the other aspect of the blood pressure formula. And same as contractility. So if your contractility is good, then it means that your ejection, or what's coming out of the heart, would be greater, and so that can potentially increase the cardiac output. And just because we've already listed it, beta 2 will cause bronchoconstriction, which is not really applicable to this lecture. So the focus is looking at when you have the sympathetic nervous system, you want to think about activation of the sympathetic nervous system. Why does it increase blood pressure? And some of the things that you're looking at as its ability for the catecholamines to bind to alpha 1 and alpha 2, causing vasoconstriction and increasing that PVR or SVR, and catecholamines binding to beta 1 receptors in the heart, increasing contractility and heart rate, which can then potentially increase the cardiac output, increasing blood pressure. So we'll now examine what are some of the things that will help to regulate blood pressure. And so we just mentioned about the sympathetic nervous system and the effect of catecholamines on blood pressure. But one thing to point out here are baroreceptors. So baroreceptors are like pressure gauges or a barometer. So if a person's blood pressure falls, for example, baroreceptors will pick up that signal. Why do they? Is because of their location. So where are they located? Areas that is essential organs. So requires blood at all given times. So these baroreceptors are located, for example, in the carotid arteries because we need a constant blood flow to the brain. And so if the blood pressure falls, this baroreceptor gets activated, and it will then send a signal to the medulla. And in the medulla, that's where you're going to have the activation of the sympathetic nervous system. So think again, your blood pressure just dropped for whatever reason. That signal will go to the SNS, and previously we mentioned as a result of SNS, we're going to have activation of alpha 1 and alpha 2 adrenergic, causing vasoconstriction. And because we're vasoconstricting, that's going to increase the SVR, which is one part of that blood pressure formula. It will also activate beta 1, which is one heart, increase in the heart rate and the contractility, which can then increase cardiac output. So if you go back to that blood pressure formula, blood pressure is cardiac output times by systemic vascular resistance. So we're seeing how SNS can then increase that blood pressure. Vascular endothelium, and so there is something in the blood that can be, and there are many different kinds of it, and there's a lot of research exploring, especially in patients with hypertension, does this have something to do with it? So there's something called endothelin, and one of the functions of endothelin, it really causes significant, it's a very potent vasoconstrictor, and so it will result in vasoconstriction of the blood vessels in the body. And as the blood vessel becomes vasoconstricted, again, we're looking at an increase in systemic vascular resistance or peripheral vascular resistance. The renal system. So going back to the renal system, we know that again, if there is a decreased blood flow to the kidney, so that what we call the glomerular filtration rate is dropped or something happened, it's going to cause the activation or the release of something called renin, which will then eventually form angiotensin 2. And so a couple of things that's released from the renin, angiotensin, aldosterone system is angiotensin 2. And just like endothelin, angiotensin 2 is a very potent vasoconstrictor. And now it's becoming repetitive where we know that if it's a vasoconstrictor and it's a potent vasoconstrictor, it's going to increase that SVR or the PVR. And one other thing is released here because of that angiotensin 2, aldosterone. And aldosterone is retaining sodium and water, increasing blood volume, and ultimately will increase the cardiac output. When it comes to the endocrine system, it kind of correlates to the renin-angiotensin-aldosterone system. So we know that on the kidney, there is the adrenal gland. And we know coming out of that adrenal cortex, so just above the kidney, there's a little triangular shaped gland, and we call the endocrine gland. Coming out of the adrenal cortex is aldosterone. And aldosterone, we just established, retains sodium and water and ultimately increases the blood volume. And so what triggers or what stimulates this release of the aldosterone is often the release of angiotensin 2. So hypertension, also termed high blood pressure, is a silent killer. And so why is it termed a silent killer? Because often patients or anyone can be hypertensive and completely goes unnoticed or asymptomatic for years upon years until complications associated with hypertension starts to occur, and often patient then starts to present with complication associated with long-standing uncontrolled hypertension. So what is hypertension? According to the Lewis textbook, it's really a systolic blood pressure that is greater than 140 millimeter mercury, or a diastolic blood pressure equal to or greater than 90 millimeter mercury. And so there's estimated 7.5 million people in Canada that lives with hypertension. But again, it could be higher than that, as many individuals, probably many Canadians, do not go regularly to their doctor, their family doctor, their healthcare provider, or don't check their blood pressures at home, so they are not aware that their blood pressure is elevated. And so one of the things to also recognize is hypertension is one of the most significant modifiable risk factor to result in cardiovascular diseases and increased mortality in Canadians. And so if you remember what modifiable is, it really is the ability to change your risk factor. Now, can you change the fact that you are hypertensive? Probably not, because you're predisposed to hypertension because of your age, your genetics, etc. But controlling your blood pressure, reducing that risk, is really, really important for the patient. So looking at the categories of hypertension, there's two big categories of hypertension. So the first is essential, and that's the most common is primary or essential hypertension that you would see in clinically. Secondary hypertension is another form or category of hypertension. So how do they differ? With primary or essential hypertension, as it says here, it's idiopathic. So the risk factor is unknown, or the cause is unknown. So we know what the risk factors are, but the exact cause is unknown. So when we think about risk factors, start to think about those modifiable, so things that you could change, and non-modifiable risk factors. It accounts for 90 to 95% of the cases of hypertension seen clinically, whereas secondary hypertension, the blood pressure is elevated with a specific cause. So often the increase in the blood pressure is secondary to a primary problem. So for example, you have renal disease, that gives here an example of nephrosclerosis, or you have some sort of endocrine disease where you're making too much aldosterone, retaining sodium, retaining water, increasing the blood volume and increasing the blood pressure. If you treat the underlying or the primary problem, that would ultimately reverse the blood pressure. So if you were to treat nephrosclerosis, then ultimately that will help to reduce the blood pressure. However, with primary or essential hypertension, because the cause is unknown and we're only working with risk factors, it means that the only way to sometimes manage and treat primary or essential hypertension is with medication, and for sometimes a lifetime of medication, along with non-pharmacological interventions. So what do I mean by that? Things like look at weight loss, salt intake, smoking, so might want to quit smoking, alcohol consumption, etc., etc. So looking at the risk factors for primary hypertension, just the easiest way to do it is to break it into modifiable risk factors and non-modifiable risk factors. On the slide, they're not separated into, but think about modifiable risk factors are as things that you can change. So for example, heavy alcohol consumption, cigarette smoking, diabetes mellitus. You may not be able to change having diabetes mellitus, but controlling your blood glucose level. Elevated serum levels, high dietary sodium intake, living a sedentary lifestyle, those are all modifiable, whereas non-modifiable risk factors, advancing age, a family history, your ethnicity, will not be something that can be modified. So let's look at the pathophysiology for primary hypertension. We know that there is no cause. It is idiopathic, but it accounts for 90 to 95% of hypertension that we see clinically. What they notice, so remember again, blood pressure formula is blood pressure equals cardiac output times your systemic vascular resistance or peripheral vascular resistance. Now, what they notice initially with primary hypertension, there will be an increase in cardiac output, but that is truly not the reason for the prolonged uncontrolled hypertension. So the hallmark of primary or essential hypertension is an increase in SVR or PVR. So really the true reason is there is a sustained increase, and we know that what is that caused by, or what is resulting, or what has to happen in order for the SVR to go up. And we know that is a change in the diameter of the blood vessel. So as blood vessels get smaller, there is more resistance. So walking through the patho, we know that it's idiopathic, but what we do see with essential hypertension, there is widespread arterial vasoconstriction. So arteries in the body gets vasoconstricted. Now again, the exact reason behind that is unclear. Is it because of genetics? Could it be because of ethnicity? Could it be because of those endothelin that we spoke about earlier that research is being conducted on? So the exact reason behind why this arterial vasoconstriction is occurring is unclear. As a result of this arterial vasoconstriction, it means that there is increased resistance to blood flow, and it also means that the workload, so if you think about who's pumping or which side of the heart is pumping blood into arteries, that will be the left ventricle. So because there's increased resistance there, you're now going to have an increase in blood pressure, resulting in hypertension, essential or primary hypertension. So as mentioned before, the difference between primary and secondary is with secondary, there is a primary reason. So if you treat the cause, identify and treats the cause, that would control the blood pressure. Unfortunately, with primary or essential hypertension, there is no cause. We know there are risk factors and we can manage those risk factors, but sometimes the patient needs to still be taking pharmacological agents or medications to control their blood pressure for life. So we're not going to go through all this. So again, looking at genetics, sodium and water, so consuming too much salt and water can make the blood pressure worsen, even though you're diagnosed with primary or essential hypertension. Large consumption of sodium and water can increase that blood pressure. Alterations to the renin-angiotensin-aldosterone system obviously will release angiotensin II and aldosterone, which are both going to worsen the blood pressure and increase it. Stress will increase sympathetic nervous system activity, which therefore means that you're going to have tons of catecholamines in the body attaching to alpha-1 and alpha-2 receptors, causing vasoconstriction, and attaching to beta 1, increasing the heart rate and contractility, worsening the blood pressure. Insulin resistance also has an impact or is correlated to worsening your blood pressure. We talked about endothelial dysfunction with an increased release of endothelin and obesity. So looking at the complications that can occur with primary hypertension, there are many complications that can occur. So things like hypertensive heart disease, which is involving coronary artery disease or having a heart attack, left ventricular hypertrophy, heart failure, cerebrovascular accident, or which is commonly known as a stroke, peripheral vascular disease, nephrosclerosis, and retinal damage. So when we look at why does hypertension result in all of these complications, one of the first things that occurs is when we look at coronary artery disease, strokes, peripheral vascular disease, they have something in common, and that is you're at an increased risk, or your patient is at an increased risk for all of these because of atherosclerosis. Atherosclerosis is a buildup of lipids or plaque in the blood vessel wall. So when we say atherosclerosis, this is a buildup of lipids or fats in the blood vessel wall, which then means that they start to narrow, not supplying oxygen to that organ. Hypertension increases a patient's risk for atherosclerosis. Now, the exact mechanism behind that appears to have multiple factors involved, and it's not just one reason of hypertension ultimately resulting in atherosclerosis. Now, when we look at left ventricular hypertrophy, as mentioned on the previous slide, the left ventricle is pumping blood into arteries, and we know with primary or essential hypertension, the arteries are very much vasoconstricted. So as the left ventricle is trying to eject its volume into very narrow vasoconstricted blood vessel, as you can imagine, it's hitting a lot of resistance. Resistance equals increased workload. So that left ventricle is working very hard to kick out its blood volume. And by doing that, just like you would go to a gym and work out, the harder the ventricle works and the more resistance it's faced with from these vasoconstricted blood vessels, this ventricle will start to enlarge over time, resulting in left ventricular hypertrophy or enlargement. Now, unlike skeletal muscle, as the ventricular muscle, the myocardium gets bigger, it actually starts to weaken. So the larger the muscle or the myocardium of the ventricle, the weaker that ventricle becomes. So almost like these will go hand in hand. As the left ventricle starts to hypertrophy, over time, the patient's heart is also going to start to fail. Nephrosclerosis, thinking back to, again, what is the patho involving primary essential hypertension? And the first thing that comes to mind is that arterial vasoconstriction. No artery really is spared. And so, as you can start to think, renal artery, which is the artery taking blood flow to the kidney, the renal arteries are also going to be vasoconstricted, resulting in decreased blood flow to the kidney, and over time the patient is going to end up with renal disease. The pathogenesis for retinal damage is pretty much aligned the same way as with the vasoconstriction, decreased blood flow to these organs, ultimately resulting in damage and destruction over time. And so this is just a little diagram to show what are some of the areas that can be affected with long-standing uncontrolled hypertension. So retinopathy to the eyes with damage, brain, you're at risk for strokes, both hemorrhagic, which is bleeding, and that's going to be covered in another topic. but also embolic. Atherosclerosis, as you've seen there, which is a buildup of lipids. Heart diseases, so you can end up with heart failure, a heart attack or myocardial infarction, renal disease, so nephrosclerosis, and chronic kidney disease. So going back to initially what we said, this is why hypertension is termed a silent killer. So when the blood pressure becomes elevated, your patients may not be symptomatic at that time. So they may not present immediately with a headache, visual disturbance, chest pain, feeling unwell. So they might be having hypertension for some time before they start to recognize, and often the symptoms that they might start to present with is symptoms associated with organ damage. So with the eyes, the kidneys, with the heart, etc. And then they realize that they had been struggling with hypertension for some time, which went unrecognized or undetected. So as mentioned earlier, hypertension is a lymphatic or what we call a silent disease. So often patient will be completely asymptomatic. So they do not present with any symptoms until there has been target organ damage. So some of the organs, as we discussed earlier, the eyes, the kidneys, etc. And so if they do become symptomatic, usually it's often because the hypertension is quite severe. And so because of the significant vasoconstriction of the blood vessel to target organs and tissues, causing increased workload on the heart as well, then there might be some symptoms that are associated with the vasoconstriction to these organs or increased workload on these organs. So some things that the patient might complain of is feeling fatigued, reduced activity tolerance. They might experience dizziness, some palpitations because of the increased workload on the heart, chest pain as well, or angina, if they feel short of breath. Also, it could be other things in there like headache, blurred vision, etc. So refer to table 35 for other complications and other clinical manifestations that can be associated with hypertension. Areas that are frequently damaged, just to recap, heart because of hypertensive heart disease. So think about what I mentioned earlier, heart attack or coronary artery disease. Patient can end up with hypertrophy or enlargement of the left ventricle. Heart failure can also occur. In the brain, you can end up with a stroke or what is called cerebrovascular accident. You can end up with peripheral vascular diseases, again, secondary to that atherosclerosis. Kidney damage, so end-stage renal disease or nephrosclerosis can also occur, and damage to the eye or retinal damage. So how does hypertension diagnosed? Obviously going to your healthcare provider regularly, able to monitor your blood pressure, and often the diagnosis is not made with a single reading that is high, so it will be over a course of time, taking that blood pressure repeatedly and comparing, is it sustainably high, greater than 140 millimeter mercury systolic or diastolic of greater than 90. And then interventions needs to be put into place. The healthcare provider completing a thorough history and physical exam, and also doing blood tests. And what to include in those blood tests is very important, are renal function, so BUN and creatinine, because we want to see, is there target organ damage to the kidneys at this point. There's many processes within the body that can worsen the existing hypertension. So as I explored earlier, endothelin is one of those things that can be released in the body, or looking at genetics can also worsen the blood pressure. But one of the biggest offender is looking at the renin-angiotensin-aldosterone system. And so if you recall, we said there is arterial vasoconstriction when it comes to hypertension, essential or primary hypertension. And that arterial vasoconstriction means that there's going to be decrease blood flow going into the kidney or decrease GFR. So as a result, we have renin that is getting released, and that renin is now able to convert angiotensin coming from the liver into angiotensin 1. The lungs actually is going to release ACE, or what we call the angiotensin converting enzyme, and ACE will now convert angiotensin 1 into angiotensin 2. Angiotensin 2 has some properties, as we explored earlier, that really can increase someone's blood pressure. So angiotensin 2, as you look at here, it is a potent vasoconstrictor. So this here, right here, is a potent vasoconstrictor. And as you're seeing, once it hits the arterioles, it will start to vasoconstrict the arterioles, ultimately resulting, going back to the blood pressure formula, an increase in PVR or SVR. What it also does, it goes to the adrenal cortex, so the outer part of the adrenal gland, and it's going to release aldosterone. And aldosterone will retain sodium, which will then retain water, increasing the blood volume, increasing the blood pressure, and worsening that blood pressure. So when we look at, what does this mean for us is many healthcare providers are now looking to treat, or found that some of the best treatment for hypertension that also has renal protection is looking at medications that kind of tackle or work on this renin angiotensin aldosterone system. So this is just a recap slide from the previous slide to say that renin angiotensin aldosterone system plays a significant role to regulate blood pressure and blood volume. Obviously, even though it sometimes acts as a compensatory because of the vasoconstriction and the less blood flow to the kidney, it actually worsens the patient blood pressure. So you end up with high content of renin, which therefore means, as again, reviewing the previous slide, it converts that angiotensin into angiotensin 1, which then gets converted by the ACE enzyme, angiotensin converting enzyme, into angiotensin 2, which will, 1, vasoconstrict arterioles, worsening SVR, and 2, triggers the adrenal cortex to release aldosterone, retaining sodium and water, increasing that blood volume, increasing cardiac output, increasing that blood pressure. So looking at the treatment of primary hypertension, we'll be only looking at the medication therapy in treating hypertension. Obviously, there are many other non-pharmacological ways that patients can use in the management of their uncontrolled hypertension. Looking at medication, there's a variety of medications. There can be combination of medications. Sometimes it's really a trial and error, because what might work for one patient may not work for the other. And so sometimes it takes some time in order to really come up with a combination or a single medication that best fits that client. So looking at some medications that can be used, diuretics, so the thiazide or thiazide-like diuretics, ACE1, ARBs, angiotensin 2 receptor blockers, which is not covered, calcium channel blockers, which we'll discuss, beta blockers, or single pill combination. Now, as it says in the little block here, what are recommended? So ACE inhibitors combined with a calcium channel blocker or an angiotensin 2 receptor blocker are often recommended or seems best fit to control primary or essential hypertension. So we will explore diuretics very high level. We'll look at an ACE inhibitor, calcium channel blocker, beta blocker, and alpha-1 adrenergic antagonist or adrenergic antagonist. So let's look at the treatment of hypertension. So more on a high level, looking at diuretics. So at this point, we would not be exploring specific diuretics, but if you think about diuretics, diuretics means to diurese, or diurese means to void, to lose water. And usually, if you think back to how the body retains water, we retain sodium, really at the loop of Henle, and then following that sodium is water, which then goes back into the body, and we're able to maintain blood volume that way. When patients experience hypertension, if we want to reduce the blood volume, reducing cardiac output, one of the medication that we could use is our diuretics. And so generally, as an overall, the way the diuretics work is they prevent the reabsorption. So they decrease reabsorption of sodium and water, and that then will decrease the blood volume. And that's why the kidney is here, because it's showing you you're going to increase your urine output. Okay. Next medication that we could look at is our peripheral adrenergic antagonist, or what we can call our alpha-1 adrenergic antagonist. So we could look at our alpha-1 adrenergic blockers or antagonists. And so the drug, or the prototype medication, was doxazosine or Cardura. So doxazosine, trade name is Cardura. So if you recall, alpha-1 binds with catecholamines and it results in vasoconstriction of blood vessels. If you were to administer an alpha-1 adrenergic antagonist, it means then that you're preventing epinephrine to binding to these alpha-1 receptors in the blood vessel. And ultimately what will occur as an effect is, because we're binding and preventing catecholamines from attaching to these alpha-1, instead of vasoconstriction, there will be vasodilation. And because of the vasodilation, what you want to start to ask yourself, going back to the blood pressure formula, that's going to decrease PVR or SVR, reducing the blood pressure. Okay. Another medication that can be used in the treatment of blood pressure is your calcium channel blocker. So we can also use calcium channel blocker. And so the drug that was selected, or the medication that was selected, was nifedipine. And we know calcium is required for smooth muscle contraction or skeletal muscle. So it helps with the contraction of muscles. Smooth muscle, vascular smooth muscle, is not any different. So calcium, when it's present and it's released from its storage site, will bind and cause sliding filament to occur, and you'll end up with smooth muscle contraction. When it happens in blood vessels, that is vasoconstriction. By administering a calcium channel blocker like nifedipine, you're preventing calcium from leaving their storage sites and binding to blood vessels to vasoconstrict. And so what that's going to do is very similar to what we see with our alpha adrenergic. It's going to result in vasodilation of the blood vessel, which again will then decrease the PVR and decrease the overall blood pressure. Another drug that is selected is beta blockers, also beta adrenergic receptor blockers. And so anything that ends in olol would be what you'll be looking at. So with the beta blockers, anything that is end in O-L-O-L is a beta blocker. So there's many that you can look at: metoprolol, there is propanolol, labetalol, etc., atenolol. So how does it work? So if you go back again and think, where are my beta adrenergic receptors? Beta 1 is in the heart, beta 2 in the lungs. So I'm focusing on my beta 1. When epi binds to beta 1, it increases heart rate and increases contractility. But I'm giving my patient a beta adrenergic blocker. So by blocking epinephrine, what you will now start to see is decrease in heart rate and decrease in contractility, resulting in a decrease in cardiac output. What you're also noticing, it can also reduce the overall sympathetic vasoconstrictor tone, and it can help to inhibit the release of renin, from the kidney. So it has a couple of effects in controlling or reducing the blood pressure. So it's acting on decreasing cardiac output, and it also has a tiny bit of effect on the systemic vascular resistance, or the PVR. Then we have our drug, the ACE inhibitors. And so ACE inhibitors, your prototype is enalapril. But you want to look at any medication that ends in april. So the easy way really to remember it is ACE, A for ACE, A for April, anything that ends in april. Now your prototype is enalapril, but you could start thinking about all the other medications, or if you see medications out there such as captopril, lisinopril, etc., perindopril, they are all ACE inhibitors. So how do they work? So just recalling again from anatomy, where does the ACE enzyme work? It comes from the lungs, and it converts angiotensin 1 to angiotensin 2. We know that angiotensin 2 is a very potent vasoconstrictor. So by blocking or preventing the conversion of angiotensin 1 into angiotensin 2, it means that my blood vessel is now going to be vasodilated, decreasing the PVR. It also therefore means that it's going to inhibit renin release as well, aldosterone release, because remember, angiotensin 2 stimulates the adrenal cortex. So by blocking aldosterone, you're going to have sort of a diuresis effect. So it's preventing sodium and water from being retained, ultimately increasing urine output, decreasing the blood volume, decreasing the overall blood pressure. So just to wrap up, just test your knowledge. Please indicate a true or false for the following statement. Primary hypertension occurs as a result of a specific cause. Is this true or false? So if you've picked false, you're correct. False because primary hypertension, as you recall, is idiopathic. There is no real specific cause. And so this is why we're unable to cure, because we know secondary hypertension is as a result of a specific cause. And if you treat the cause, then ultimately you can reduce or decrease the hypertension. So the answer is false. So next question we can try, which of the following medication or medications would treat hypertension by decreasing the systemic vascular resistance? Select all that applies. So with this type of question, you would first need to recognize or identify which classification does your medication belong to, and then what is the mechanism of action of the medication in order to come up with the answer. So let's look at the first one, diuretics. So as soon as you see the word diuretics, diuresis means to pee. So I'm losing sodium, It's preventing the reabsorption of sodium. So ultimately, your patient will be losing sodium. They then will lose water, decreasing the blood volume, decreasing the blood pressure. So does it really impact the SVR? No, it doesn't. Doxycycline, so which classification of medication this is? The other name is Cardura. It is an alpha-1 adrenergic antagonist. We remember that alpha-1 receptors are located in the blood vessel, and when catecholamines bind to alpha-1, it causes vasoconstriction of the blood vessel. So if we're preventing catecholamines from binding, there will be vasodilation of the blood vessel. If the blood vessels vasodilate, then you're going to have a decrease in the peripheral vascular resistance, or SVR, decreasing the blood pressure. Enalapril, so anything with prils are ACE inhibitors. And so when you think about ACE, it prevents the conversion of angiotensin 1 into angiotensin 2. Angiotensin 2 is a potent vasoconstrictor. So if I don't make angiotensin 2, my blood vessels are going to vasodilate. And then we have our nifedipine. And so what is nifedipine? So if you came up with calcium channel blocker, that's correct. And so what does it do? Prevents calcium from going into vascular smooth muscle, which means contraction will not occur, but rather relaxation, resulting in vasodilation of the blood vessel. Once there's vasodilation, the vascular resistance will also go down. So your answer is also nifedipine. So when you have something like this, select all that applies, your answer will be B, C, and D. Thank you for listening to this lecture and watching the video. The reference used is provided here.